Welcome to the Neuroblastoma Parent Global Symposium. My name is Vicky Inglis and I'm the head of the Family Support Services here at Solving Kids Cancer UK. And my son Jamie was diagnosed with high-risk neuroblastoma, so I am a neuroblastoma parent, and I understand the impact of a childhood cancer diagnosis for you as parents, and the impact of this on your child too. I will be moderating this session, which is PTSD and post-traumatic growth after childhood cancer, which is being delivered by Dr. Hilary Van Horn-Gatlin, who is Chair of Chiefs, Behavioural Medicine at Kaiser Permanente. Before I hand over, I'd like to draw your attention to the Q&A button at the bottom of the screen to submit questions during the session for the speaker to address at the end. If the button is not showing, just tap or hover your cursor to bring it up. If you see a question there that you like, do give it a thumbs up to move it up to the list. And it's over to you now, Dr. Van Horn-Gatlin.
Thank you, Vicky. I appreciate it. I'm going to share my screen and we will get started, everybody. All right. So today we're going to be talking about post-traumatic stress disorder, post-traumatic stress, and post-traumatic growth. And specifically, we're really thinking about this in a couple of different ways. So first, I just want you to know I have nothing to disclose, no interests anywhere. And really to give you a roadmap of what this is going to look like, we're going to be talking about distress and treatment, distress beyond treatment and survivorship and remission, risk factors and protective factors, and kind of clinical interventional support needs for families. So first, I really want us to think about this, and you know this, you live this every single day. Cancer in the family system is an impact not just on the person who's diagnosed, but it's an impact on everybody. It really is a ripple effect. And so when there's a cancer diagnosis, there's changes to every single family member's routine, whether it's a sibling, whether it is the child themselves who is diagnosed, or whether it's a family member, a grandparent, even friends. And so we think about how time is spent differently, the amount of time that we're at home, if you're the healthy sibling or the child who's been diagnosed, introduction to new people in our lives, people that we hope to never meet in our lives, that we're spending a significant amount of time with, time away from our children who are healthy or from other siblings, time from school and from work. The differences in holidays and special occasions. Most of you have probably spent a holiday or a special occasion in the hospital now. And really the interruption of those developmental tasks. So whether your child is an infant toddler at diagnosis or whether they're 17, there are different developmental things that we do as we get older. And when we have a cancer diagnosis, a lot of that is interrupted. And then we'll also talk quite a bit about changes in self-image, how we see ourselves and how we feel about ourselves. And that's really more in relation to our children with a cancer diagnosis. So first, I'd like us to think about distress, psychological distress. A lot of studies have found high parent distress during and after treatment. In fact, we found that parents tend to have more distress before, during, and after treatment than the actual child with the diagnosis. Some of these findings are more inconsistent though. We know that mothers tend to report more what we call intrusive thoughts, so kind of worst case scenario thoughts, and more fear of recurrence. They tend to have more anxiety going into appointments and scans than their male partners. But we also know, again, that range is broad. And so there are studies that say only 10 to 44% of parents are reporting post-traumatic stress that's severe. And there's a big difference between 10% and 44%. But when we look at meta-analyses, we do know that, even if you were to average it out, if you look at lifetime stress levels of a lot of these family members and parents in particular, you're looking at an average of about, 35%. And one of the big things that we know, though, is that these limitations are based on measures. So they send you respond to a questionnaire, and that's really how we're making a diagnosis, as opposed to the best means of diagnosing post-traumatic stress, which is through a clinical interview. So asking really deep questions, because oftentimes, and this is where I get on my soapbox every year, and I swear one of these years I'm not going to do it. It's hard seeing a parent whose child was recently diagnosed with cancer, given a post-traumatic stress disorder diagnosis, when a lot of the symptoms that they're having are a completely reasonable reaction to what happened and where they're out and what it continues to happen. And oftentimes there's a tendency in groups that aren't as familiar with pediatric cancer to overly pathologize a process that is in and of itself biologically pathological. And so the things though that we know that are related and put you as a parent at greater risk of distress that gets in the way of your functioning. And I think that's a better way of looking at it. The stress is so bad that it's getting in the way of your functioning. We're looking at a couple of these things. So we know the risks are people who have a lower quality of life, who are reporting functional disabilities. So like, I cannot go to work any day because I cannot concentrate at all. I am constantly on edge waiting for something horrible to happen. People who report parenting challenges are at greater risk. And we also know that those with those post-traumatic stress symptoms have more what we call somatic disorders. And so those are things like common complaints of migraines, chronic pain. Oftentimes people report a lot of stomach or GI distress. And so we're looking at that as really kind of a sensational sense of distress. One of the ways that we know, though, that this is important and really, I think, a consideration for your family, for yourself and for your children, is that how your child was doing before diagnosis is a good predictor of how you're going to be doing and how your child's going to do. So again, we call that pre-morbid functioning, so before the diagnosis. And so we know that children who did not have previous traumatic life events, or one of the things that in the United States we're talking about a lot right now is what we call adverse childhood events. We know that those children tend to have less significant and fewer occurrences of post-traumatic stress syndrome and symptoms. And we also know that, that prior traumatic life event and that cancer-related stress, can increase what we call hyperarousal. So hyperarousal is just feeling physically very anxious. We tend to be a little bit jumpier. We tend to be, less comfortable. And then intrusion, which is really negative thoughts. And oftentimes it can be trauma related, or it can be related to the cancer diagnosis and treatment. Another thing that we know, though, is that the assessment of long-term late effects, so when we do late effect survivorship assessments, that we know that survivors can, experience those levels of distress even 10 years to decades after diagnosis. And, some of you may be listening to this and feeling very overwhelmed, like it's one more bad thing that you have to prepare yourself for, especially if you're still in treatment. But I do promise that there is a lot of hope, and we're actually seeing a lot of really important information that's helping us rethink what post-traumatic stress is and what we actually do with it. So one of the things that we talk about that can be a related factor is the change in that parent-child relationship. So if you think about yourself as a parent to your child with cancer before their diagnosis and now, my guess is you're going to say it's very different, correct? One of the things that we know is that, children are very keyed into how we're feeling. And when they're spending more and more time with us, and sometimes only us, they're paying more attention to how we're coping with things, how we're responding to things, how we're responding to things or reacting. And so we know that parent distress, so when we as parents are having a hard time, is considered a more significant risk factor for our children being also distressed. So if our children see us feeling out of control, they're more likely to feel out of control themselves. And so some of the changes in behavior that we talk about is we talk about scaffolding, so decreased scaffolding. So the rules and laws around everything that we apply to our children change. There used to be a set bedtime. There used to be a set wake up time. You had to eat this much food off your plate. Your job, what I keep doing with my kids right now over and over and over again, and I'm fighting a losing battle, is just you need to take your shoes and put them away. Don't leave your shoes. So all the little rules that we have, even around school perhaps, or, how quickly they get their homework done, how they do if they're in school, of, taking their tests, the expectations that we have on them. All of all of the rules change, and most of them are actually just completely gone. We just say, forget them. None of that's important. But when there's so much other change going on in our children's lives, we actually know that that leaves them feeling more out of control, and it can feel very frightening because there's nothing that's predictable anymore. We also know that parents who have a really hard time and emotionally feel disengaged while their child's in treatment, if we have parents where their child's not feeling well and every single time their child feels like they're really, really struggling and they're crying and the parent has to get up and leave the room, that can feel very, very upsetting and concerning for the child. It doesn't feel as safe. And then increased hostility towards others. Anger is a common reaction as we process a cancer diagnosis and as we go through some aspects of treatment. And oftentimes that anger is because as parents we're scared, we don't know what's coming next. We just want this to go away. We want this to get fixed. We don't like watching our child suffer. But our children can pick up on that as hostility. And oftentimes that again leads to a greater sense of feeling out of control and uncertain. So I want us to rethink cancer survivorship as family survivorship. I'm going to tell you a little bit about why. So when we talk about distress markers, so the things that we're looking for, this is what we're looking for. So in parents, we're looking for depression, we're looking for anxiety, and we're looking for post-traumatic stress symptoms. And again, we talked about already, those tend to vary across studies. There's no good study, even the meta-analyses that they've done, have found really, really inconsistent, findings and reportings. Again, based on whether it was just a measure that somebody filled out or a clinical interview. When we think about survivorship distress, we're looking at this as a more population specific issue based on child's age of diagnosis, where they're at right now, and again, how they were doing before cancer diagnosis. What we do know is that, as they cut that information down further, there's less depression than people oftentimes anticipate. But we also know that especially with our adolescent and young adult survivors, they have a higher risk of some of those symptoms. They have a higher risk of distress. And oftentimes, because as we think about it developmentally, there's things that they haven't done, or they're really trying to become more independent while also going through treatment, it gets in the way of who they want to be. And so oftentimes some of the stress that we see there and distress that we see is in relationship to those two things. So again, if we think about that survivorship as a parent-child dyad, we really want to think about it as that there's a significant relationship between parent and child distress, but that's only if there's been less bad things that have happened before then. Okay, so children who've experienced a lot of traumatic life events ahead of time, it's a very, very different outcome. And we also know that, again, those cumulative exposure to stressful life events. So if we take all the stressful life events and we put them together, that this moderates that link. And so how we have gone through, survived, and worked through different distress and traumatic situations in our lives, it impacts how we cope and how we either get better or fall apart because of what's happening right now. One of my favorite quotations is that although psychological distress among parents of children with cancer has been shown to decrease as a function of time, so it gets better over time since diagnosis, some parents still have and report a higher level of distress afterwards. And some of the things that we see that are impacting that distress are things like marital strain, especially when a couple feels very differently about how treatment went, how the outcome was. If one partner is feeling a greater sense of regret or guilt even about, if we just done this, what if we had done this, particularly if their child has long-term effects from treatment. One parent may be ready to, kind of like, okay, it's time for us to move on. We're going to move forward. And the other parent saying, I am just stuck in this. Like, I don't feel like I can do that right now. That can cause a lot of strain. We also see parents who have a significant fear of relapse, and every parent has a fear of relapse. But if it's taking up essentially all of your emotional space, again, strain in relationship with siblings, a lot of parents will report a lot of guilt about, what they missed or what they weren't able to do for their other children. And then again, those economic and the financial hardships, the occupational hardships related to returning to the workplace. And so my ask is that we start a conversation, about really what we're looking at with survivorship. When we're looking at post-traumatic stress symptoms, we're looking at really specific behaviors. So we're looking at, again, that hypervigilance and the hyperresponsiveness. So really, really strong reactions, constantly watching, constantly waiting. I knew one parent who would, every single time that their child had a sniffle or just, had a side cramp from running, they'd be taking that child to the emergency room. And so, one of the reasons I was called in was because they were in the emergency room asking for scans on average at least 5 to 6 times a month. Sleep disturbances, not being able to sleep, just laying awake at night, thinking about this, wondering about this, thinking if this happens, then this is going to happen, or what if this had happened? Significantly increased irritability to the point that people have noticed it. Difficulties concentrating, intrusion. So again, those are those negative thoughts, and that can be mostly related to memories of when we were first told about the diagnosis, or memories of when my child first went through this cancer treatment, or how they responded to this. And then again, avoidance, which is, we see this more in kids than adults, where they just don't want to come back to the doctor. Any doctor, they don't want to have anything to do with it. A shot, thanks, but no. And so again, that avoidance of anything that might remind them. And in childhood cancer survivorship, many things that some of you are aware of already. We're looking at, the long-term survival being not just living, but physically, how are they doing? What are the physical costs of the treatment that they had? What are the emotional changes, the psychological changes? Surprisingly, a lot of children, and we'll talk about this in a moment, will report a greater sense of hope and kind of a can-do attitude compared to their peers. Socially, how are they doing? This is often a place where they really struggle, especially depending on how long treatment's been. And then adaptive functioning, being able to make friends, go to school, complete tasks, get a job, and maintain relationships and into adulthood, and really kind of become independent from their parents, which is oftentimes extremely hard. And then lastly, one of the things I always talk about is we think about siblings. So research has generally found that siblings tend to do well in general, but there is a small group of siblings that tend to really struggle. And we know that those children are at a higher risk of behavioral issues. They tend to get in a little bit more trouble at school, maybe biting if they're in a preschool. If your preschooler bites, it's okay. But I'm just saying, a lot of biting, for example, having really a difficult time emotionally, kind of adjusting and being bouncy. And again, for all of us as parents, that difficulty in letting go and allowing our child as they get older to take more control of things. And so we know that the autonomy and independence that's part of our job in raising our children tends to get delayed. And in some cases, it's really hard as a parent to allow them to take those next steps. So I know that we're almost out of time and there's going to be questions. So I want to go really quickly and just talk about this in a different way, which is that, again, time since diagnosis, gender, and social support are all aspects that increase the likelihood of you coping well. And we really want to think about this in a different way, which is that there is hope. And this is where we talk about post-traumatic growth. So post-traumatic growth is this concept that through something traumatic, and frankly, because of something traumatic, something changed and you grew in a way that you would not have been able to, that wouldn't even have been possible had this not happened to you. And it doesn't mean that you're grateful for the experience by any means, but it does mean that you changed who you are, what you do, how you relate with people because of this incredibly traumatic thing that you've experienced. And we know that parents with children with cancer tend to have greater reports of post-traumatic growth than others. And so this is where we talk about resilience. So we think about resilience as, again, being able to adapt to what happened and change and kind of flex because of it. And really using that adversity to grow and change. And so some of the constructs of post-traumatic growth that you probably have noticed in yourself, no matter where you're at in this, a sense of new opportunities has emerged. Maybe you're changing jobs, change in your relationship with others, increased sense of your own strength. Like, I did not know what I was capable of until this happened to us. A greater appreciation for life in general, like what's valued, And a lot of people say a deepening in spirituality. When my godson was diagnosed with cancer, my best friend said, she goes, I obviously would never want him to have cancer. And there's so much I still struggle with to this day, but I'm a better parent because he was diagnosed with cancer. And it really made me rethink what was important and how I was present. And I guarantee you, everyone listening is experiencing some of those. And so just really thinking about where are the places that despite all of this, a rose has somehow grown in a parking lot. And think about this in terms of stress inoculation theory. So a quote that I really like is, there may be something about the experience of parenting a child with cancer that promotes resilience or increased stress resistance over time. And you'll see this, what other people are blowing out of proportion, you're like, that's not important to me right now. My priorities are completely different because of what has happened. And I think oftentimes as parents, we tend to put the spotlight on what we don't like about ourselves or where we feel like we're failing, as opposed to putting the spotlight on the ways that we've grown despite all odds, despite everything that's happened. And so I think about this in terms of your increased social support. A lot of parents will say, I'm more optimistic. We notice that hopefulness, so a hope and a belief and a faith in our ability to change, is one of the greatest markers of childhood cancer, both survivorship and in adults. And so moving forward, just a couple thoughts. What I really want you to watch for as a psychologist, these are the things I'm going to ask about. Are they having significant school anxiety or school phobia? Are they refusing to go to school? Panic attacks? Are your child reporting nightmares? Typically, again, specific to cancer diagnosis, treatment, and outcomes. Are they refusing to leave home? Are they refusing to come to the doctor? Is there a lot of disruption in the home? Is there a lot of chaos in the home? Are they able to interact with their same age peers? Oftentimes for a lot of our kids, it's really hard to get those interactions back down when they've been so isolated for so long. And that's okay. It's just something that we need to support them with. And then again, the big thing we talk about is, are there big concerns at school, in terms of completing tasks, getting along with peers? And for parents, these are the things I want you to look at. Insomnia, difficulties connecting with others, being very angry and consistently angry. Pervasive guilt, just overriding guilt over everything. Again, scaffolding issues, as things are getting a little bit better, are you able to bring some of the rules back? Are you able to still expect your child to take the trash out and really encourage them to do that and have that be an expectation? When they're back in school, are you able to expect them to complete the schoolwork, not because they can, and I think that's an important question. And again, that hypervigilance, that anxiety, that just feeling like constantly on edge. So how to foster it? I think the biggest thing I will say, and I know that there's a lot of questions, is, really hold this all gently. We tend to be very hard on ourselves in terms of how we should be reacting, how we should be feeling, how we should be caring for others and caring for ourselves. But there's just a lot of change. It's a lot of disruption for anybody. And that post-traumatic growth is independent of distress. So whether you're having a hard time or not, if you're having a hard time, it doesn't mean that you're incapable of post-traumatic growth. You are just as capable of post-traumatic growth. It can be both. And I really want to remind all of us that what we water grows. So what we put our time and attention into, what we put our love into, what we say is valuable to us is what we're going to create. And so I want you to also just very strongly hold on to the sense that I've done incredible things, even though it's been so hard. And these are things I never wished on myself or anybody else. And I'm amazing for what I've done, even if I haven't done it the way I wanted to. And again, survivors who experience substantial post-traumatic growth may still be distressed at times. So, that screening and support are important. So with that, I know that we're almost out of time, but any questions?
Dr. Hillary, that was fascinating. Lots of things there that I'm sure we can all resonate with, and there are some questions here for you. So one question is related to dealing, with the emotions in older children. So one of the parents' daughter is 11 years old, 2 years into treatment and due to finish next week. She understands everything is caused the parents so much stress trying to hide the emotions from her their words are, it's exhausting.
Yeah.
How would you recommend, Dr. Hillary, dealing with an older child who absolutely sense exactly what's going on?
Yeah, I think that's such a good point. You know, it's one of those things where we don't want to let them see everything, but we also can't protect them from everything, because even in doing that, they know something's going on. And that can also make it worse because they're hiding things from me, what's really happening. I think that's a really great point. And so my biggest recommendation is, and honestly, the easiest way I've seen families do this and do it well, have a regular meeting time where we just talk about how we're feeling and how things are going, but know ahead of time that it's going to happen and kind of prepare what that's going to be for you. Sometimes what will happen is we spend so much time trying to hide what we're feeling that when we finally do talk about it, we just burst. And that can also lead to feelings of discontrol. So with some families, I've seen them have, family meetings, with either just the child or the child and siblings, once a week saying, what's been good this week? What's been hard this week? How are you dealing with that? And just having, again, thinking through developmentally where they're at and not overly adulting them. A lot of times with our kids with cancer, because we spend so much time with them and they spend so much time with adults only, we start talking to them as though they're older than they really are. And while cognitively and in terms of vocabulary, they may almost be, kind of in line with us, in terms of how their frontal lobe works, in terms of how their judgment, understanding of things goes, it's not, they're still the age that they're at. And so just really thinking through that ahead of time and saying, this was a really hard week for me, that I was really nervous before that scan, and I'm glad that it came out well. And I'm just thinking that, next time I'm going to talk to you guys about it more, because I know this was a really hard week and my stomach was upset and I was just kind of grumpy all week before this.
Thank you. Another question is about the role of counselling and how the role of counselling, what role does that play during and after treatment? One family found that sometimes it drew unwanted attention to the situation among their child's siblings.
Yes, I agree. It's going to sound funny as a psychologist talking about this. I think that there is a time for counseling, and I think that there's a time that counseling is not appropriate, to be completely honest with you. I think especially for community providers, and I've seen this all the time, a family goes in for counseling because they just assume that because their child has a cancer diagnosis that they need to have counseling. That child's doing fine, and then the siblings are there and the counselor is just pushing that everything's about the sibling's cancer, and that kiddo just wants to talk about themselves because they don't get to talk about themselves about anything. So I think that there is a time and a place. My biggest rule of thumb is for the child with cancer, if the care team is recommending it, or if you're not sure, bring it up with the care team. They will let you know if they think it would be beneficial, because this is all they do all the time. They can tell you what's normal, what's not, and whether it's a little help, whether it be helpful. If it's for a sibling, I would ask the siblings, especially if you're noticing them struggling, or you feel like it would be helpful for them to have, just somebody to talk to, is just offering it up. And then really setting the guideline, I would say, with the counselor, of letting that child take control over what the conversation needs to be about and have a very honest conversation, so that even counseling is not just about their sibling with cancer, because they have other things going on in their lives that may have nothing to do with their sibling with cancer.
Thank you. I think we've got time for other questions here. Any advice on how to deal with friends and family members who seem to suffer more than the parents and child? Parents are sometimes having to deal with everyone else's grief and suffering at a very traumatic time themselves.
Yes. So this is an interesting one, because I think it's important to create that boundary and give those people resources of people that they can talk to. At the same time, I think sometimes we as parents kind of get sucked into it because it's still a distraction from how we ourselves are feeling. And so it's like, okay, if I can just focus on how they're dealing with this, I don't have to focus on myself. So I think my first thing would be to ask each of you to think about, if this is something you need to do, have you maybe fed into this problem a little bit previously because it was a distraction that you needed and now it just doesn't feel good anymore? from there, my recommendation is twofold. I think that the first thing is, there's a lot of really great support resources out there, and it's okay to say ahead of time, I'm really struggling with this. I've got support, and I'm recognizing I can't talk about this anymore with anybody. This is how I'm going to be giving information to everybody. I want to be thoughtful about it, but I also really need to make sure that I'm taking care of myself so that I'm there for my child. I needed to make sure that I'm really protecting that so that we can focus on what's important. And so I just want to let everybody know, here are some great resources of people to talk to. As when I have information, this is how I'll be sharing it. And if you do talk to me, I understand, but if I can't do it, I'm going to let you know, because I know that you'll understand, and I appreciate that. And I thank you for that.
Thank you so much. And there are more questions, Hilary. This is fantastic. Post-traumatic growth. One parent loves the idea, of this. It seems important, though, maybe to let this happen in its own time, rather than to chase it or expect it to happen.
Absolutely. I mean, there are things that you have to invest in yourself to keep going. And I don't know if I said this last year. There's that saying about putting the oxygen mask on yourself before you put the oxygen mask on the people you're traveling with. And I can't stand that saying, but there is some truth to it, in that if you're not taking care of the most basic aspects of your own well-being, you're not taking care of you. And if you're not doing that, nothing's going to end well. And so I always like to say, if life is an emotional piggy bank, and with a childhood cancer diagnosis, we're taking, 3-4 withdrawals a day, and we're not putting anything back in, not only are we not growing, but we're on a train to bad things. It's not going to end well for us. And so I think that the biggest thing is, you cannot push it, but I think that you can be very thoughtful and purposeful in saying, I recognize that what I'm saying to myself right now is not helping me, it's actually hurting me. And if what I'm saying or what I'm thinking to myself is hurting me, whether it's, maybe suddenly noticing you're finishing 1 to 2 bottles of wine a night, whether it's you're spending 7 hours on social media and it's just wasted time and you don't have anything else and you're exhausted tomorrow and you feel more anxious about your child and their well-being, then I think it's time to take a step back and say, are the choices that I'm making in line with who I am and who I want to be? And if the answer is no, I really want to push you towards, moving towards the thing that's going to take care of you.
Thank you. Another parent, Dr. Hilary, is asking, are there family activities that would be helpful, in putting PTSD at bay for both patient and parents or guardians?
Yes. Are there activities to put it at bay? I think that we're all going to suffer some symptoms of post-traumatic stress. We're experiencing something that nobody should experience. And so I think that a really probably healthy way of looking at it is, the more protective factors that we have, the better. And so when we think about this, in the United States, we call this grit, or you think about it as resilience. Those behaviors are things that are absolutely kind of work against post-traumatic stress. And so the biggest one, social support, good social support, not social support. I'm sorry, but I don't count social media alone as social support. It has to be an honest one-on-one conversation. So good social support, exercise, if you're religious, having some sort of religious connection that's helpful to you, being able to express yourself in some ways. And I think especially allowing yourself to admit when you're having a hard time, and just really reaching out to others and really proactively trying to find ways of, getting up and doing something that you're going to feel good about for yourself and for your child at the end of the day.
Okay, another question for you. A parent here talking about their survivor who doesn't remember his treatment, and as he enters his teenage years, he's struggling with things like anxiety and insomnia. Is it possible that it's a late effect, or is this more related to his personality? Very difficult question there.
Ooh, this is an interesting one. It would depend partly on just how old he was. I think most of us, if we're looking at the actual basis of the diagnosis of post-traumatic stress disorder, if there's no recollection, it would not meet diagnostic criteria. The other thing though I would say, and it may be completely not cancer related, is we know that our children are experiencing more anxiety, more depression. COVID has not made any of this easier. In the United States alone, they say 1 in 4 adolescent young adults is struggling with anxiety and depression. And I think with that, all the changes and disruptions that have come because of COVID, and then just based on developmentally where he's at. So I think that there's a lot of reasons that very understandably he could be experiencing anxiety and depression, or excuse me, anxiety and insomnia. And there are some, excellent resources both online to get started with. And, if you're not sure, I would always encourage talking to your pediatrician or your GP to kind of get a sense as to whether it's clinically significant or if it's something that needs a little bit of time and attention that is a skill he can build himself.
Thank you so much. Dr. Hillary, if there's time, I have a question myself actually, and I just wondered, there are many children at diagnosis with neuroblastoma who are under the age of 5 or who do actually go on to complete their treatment and come out of it the other end, but they're still very, very young little people.
Yes.
And I just wondered, does that impact on the rate of post-traumatic growth compared to older children?
Right.
So I just wondered what your thoughts were on that too.
So the only research that has been done on this, looking at it as age specific, is that the population that struggles the most is typically our adolescent young adults. For very different reasons. And that could be its own, I could spend an hour and a half on that alone. But with our younger children, one of the big things with post-traumatic growth is the memory itself and what they did with it. It's building up a sense of what we call self-efficacy or confidence or sense of independence about how strong they were. So I think one of the biggest predictors of post-traumatic growth is if you asked your child to tell you what treatment's been like and how it's changed them, I think that that's going to give you just a huge amount of information as to how they see themselves, and kind of how much control and independence and strength they have derived or that they want to derive from what they went through.
Amazing. Thank you so much. One more question from me. Are there any correlations between PTSD and post-traumatic growth?
So generally we found that, it can be concurrent. You can have post-traumatic distress and post-traumatic growth at the same time. It really depends on the situation, because there's a lot of situations that lead to post-traumatic stress. Some research that they've done has found that, anywhere from 30 to 50% of people with a post-traumatic stress diagnosis or a post-traumatic stress consistent situation or experience will have 3 paths. They'll have a path where they go back to normal. And I think any of us who've had a child with cancer will say there's normal's new now. So that's kind of down the middle of the road. Some will have post-traumatic growth and some will be poor off because of what happened. And so essentially what we found is that, over time, the most recent studies were that about 60% will kind of go back and forth between new normal and growth. And again, depending on the situation that induced the post-traumatic stress, anywhere between 10 and 30% will have more maladaptive functioning.
Finally, because of the parent community that are obviously invested in this, because they are the ones affected too, as well as their children, what do you think needs to be available and should, in order to support families and children, and should that support be part of the supportive care package at the point of diagnosis for both the child and the family?
Yeah, that's a great question. I think in my fantasy world, this is a fantasy question, yes?
Yeah, in an ideal world.
So in my my fantasy world, I think that there's a couple different aspects of this. I think the first is, and I think at children's hospitals, they do a great job of this, is that we need to really support our oncology team and our social workers in having these conversations at time of diagnosis. And, you know, whether you've got social worker, child life, all these different people that are really invested in the entire well-being of our child and family unit, as opposed to just their medical outcome. And I think I have yet to be at a children's hospital that doesn't do that beautifully. And I want to be really clear on that. You know, people don't go into this because they just want a job. People go into this because it's a calling. And so I think if we look at it on a more systems kind of on a more systems kind of level, I think that we need to be assessing for outcomes at different points. I think that, you know, there's a lot of really good clinical measures, both for parents, for children, and frankly for siblings, that we could be doing just to kind of see how people are coping, how they're dealing with it. I think survivorship programs are massively important. I think training more mental health providers and really better looking at childhood cancer and how to support families is important, because I think there's a lot of bad information and I think a lot of confusion around what constitutes treatment for these families. And I think there's, again, a huge tendency to pathologize something that is just a really difficult situation. And so I think with all of that, if we're doing more things preventatively, more supportively, and I think also just letting families know this is a point person that you can talk to if you're not sure, I think that would be hugely helpful for our families.
Thank you so much. And that's all of the questions answered from the delegates. I just want to thank you again, Dr. Van Horn-Gatlin. It was just incredible, and the feedback from the attendees is, you know, an amazing session, very beneficial, and parents recognizing so much of themselves as well in your presentations and the behavior. Thank you to everybody watching and for your questions. We have reached the end of this session, but next up after the break, we have the importance of aftercare, long-term follow-up, and the Naxitamab humanized 3F8 studies. Remember though, that if you do miss a session, it will be available to watch shortly after the live session ends on the on-demand page on the event website. Enjoy the rest of the symposium. It's been an incredible day so far, and thank you. Bye-bye.
Thank you all. Bye.